Hey everybody, welcome to Tea Time number 3. I'm Dr. Edward Tarnawa.
And I'm Graham Tyson, and we are here to answer all of your fertility related questions.
That's right, from Prague, Piedmont Reproductive Endocrinology Group. We're coming to you from our Somerville office here in the low country of South Carolina.
And once again, we have a great set of questions, a lot of really interesting things to talk about, so we're going to dive right in. All right, so first question that we have is this. Is there any truth that if you lose an embryo less than 3 days after it starts to grow, that indicates an egg quality issue versus one that if an embryo doesn't make it past 3 days, that it's a sperm quality issue?
You're starting me off with a hard one.
Yeah, that's why I wanted to read it first.
Sure. So what this person's asking is, let's say there's a group of embryos and a lot of them start cell division. They make it a few days in growth, but then, or in culture, I should say, I'm sorry, but then they all just stop. There's kind of a midpoint in the culture process. We call it day 3, where it's a bunch of cells, and then over the next couple days they make it to the blastocyst, the fully expanded embryo. That's what we really want. And so sometimes maybe all the embryos or a large portion of them stop at that point, and a common question we get is it the egg, is it the sperm? There is absolutely some data that says that very poor blastulation, not making it all the way to the end, getting to that day 3 point, but then stopping, there is a chance that there could be a sperm factor at play.
Yeah.
Now, it's not going to be a definite. It's going to be hard to prove that, but that gets into some fundamentals in terms of how embryos grow. The earliest stages of embryos are reliant on structures that originally came from the egg, that get that egg started in terms of cell division. But eventually, the embryo itself needs to guide its own development through gene function and transcription and protein production. And that is called, it's a fancy term, Dr. Tyson, the human zygotic genome activation.
We have a lot of those in REI, don't we?
Yeah, we do. And there's pretty good evidence that shows that transition of when the embryo is able to start to take control of its own development is around day 3, around the 8-cell stage. And factors that are paternally driven, that come from the sperm, are important in that. So if a lot of embryos are making it to the 8-cell stage around day 3 but then stop, it could be that a sperm factor led to that. But that's where looking at the sperm would be helpful, right? If we had a pre-IVF expectation of having to deal with some sperm that was iffy in terms of quality or number, that would heighten the likelihood that it was truly a sperm quality factor that led to embryonic arrest. Can't be assumed, but it can be suspected. Whereas if embryos have a hard time even making it to that day 3, 8-cell-ish stage, perhaps more indicative of an egg problem. Things are not always cut and dry, black and white. There can be some of both, but that's where, if an IVF cycle was unsuccessful for that reason, we would get together with our patients and dive into it and think about all options. But that's a really good question. I wish there was a more straightforward answer, but I think you're on the right track.
Yeah, I guess I can take the next one because this one is addressed to me. It says, hey, Dr. Tyson, what is your opinion on PRP, which is platelet-rich plasma? So that's a really interesting question. So the way that I talk to patients about this, so this is one of the various treatments that are out there that that are basically experimental. There are places where these are done under sort of experimental conditions, and there has been some data to suggest that in some situations they can actually make a difference. But the vast majority of these things, that if you were to look at ASRM, what they would call sort of add-ons, there's all sorts of things out there that that the companies themselves that are putting these things out will say, oh yeah, this makes a big difference. We've done our own trial. We've seen that there's something here. When you really collate the data, there's not a lot of evidence yet to say that we can say to you, this is going to make a big difference on an individual basis. So the short answer for this question, this is a little bit shorter than the other question, is essentially this is still experimental, and until we have more data, you will find that any sort of reputable study will say we just don't know yet whether it's going to make a large difference.
Yeah, so I think it's important to be wary, be cautious about centers that might be offering treatments that are outside the mainstream and
Mm-hmm.
making guarantees that really can't be made at this point in time. Things like PRP injections beneath the ovarian capsule has some promise, right? But still has that label of experimentality on it for a reason, and I think that should be heeded.
Yeah, there's some very, very clear things that we know do help, and those are the things that your doctor should be talking to you about. You know, they should take your specific condition, whatever has led to your infertility, or if you and your partner have unexplained infertility, there's a very specific set of things that we know work, and those are as cut and dry as they can be in the world of infertility. Anything that sort of falls outside of that realm. What I always tell patients is I'm willing to do it. I'm willing to talk about it, and if it's something that we can offer, we'll think about it. But I'm always honest to patients to say I can't tell you for sure that this is going to make a difference, and I can tell you for sure that it will cost more money. So you know your job with your doctor's job should basically be to optimize every single dollar for the best chance of baby, however you can get there the fastest and the most cost-effective way. And things like this, they just don't fall under that category yet.
Yeah, and I think that's a pretty good segue to another question here down the list where it says, I've had 4 IUIs without a diagnosis or reason why we are infertile. Should I be looking for a diagnosis before IVF? That is the essence of the dreaded term unexplained infertility, right? Patients don't like it. They don't like that term. You mentioned before about exploring some atypical or outside the box or revolutionary or new or unproven treatments. It is human nature, and it's normal and it's understandable to want to get some answers, right? And that whole term, unexplained infertility, we don't have an answer. That's okay. Sometimes I'd rather not have an answer, you know what I mean? But to me, the term unexplained infertility equals options, all right? And depending on age, a really, really good prognosis.
Yep.
So in this case, it sounds like somebody has unexplained infertility looking for a diagnosis. Well, ideally, that's done from the front end, right? Before you make a treatment plan, the evaluation should be done, and we would talk to you about the recommended components of
and I
a
should say
fertility
that
evaluation.
is a diagnosis. You know, if you have
is.
gone through the workup for the typical things that we can detect that cause infertility, and all of those look normal, then you do have a diagnosis. The diagnosis is unexplained infertility. And I always say this to patients up front. It doesn't mean it's actually exactly what you said. It doesn't mean that that's the end and we can't do anything. It just means we know what options work for you and which ones won't.
Yeah.
And a large number of patients come in with unexplained infertility. It's really, really common actually, but it is frustrating for patients sometimes to say, "Well, I want to know what's going on."
Sure.
What I always say to patients is basically, there are some things that we know are not working. So it's maybe an egg and sperm coming together issue. Maybe there's cervical factor, but they're sort of beyond our ability to detect with the technology we have right now. But it doesn't mean that we don't have the technology to help you get pregnant anyway. That's kind of what I talk to people before you even do the full workup, because I know that a lot of couples are going to come back and have unexplained infertility. So I want people to know from the onset, if we see it, it's not the end of the world.
Sure. I mean, there's a million molecular steps that have to happen between ovulation or getting ready to ovulate and implantation and establishment of an ongoing pregnancy. And we just can't hone in on each and every one of those. Now, we do have a particular treatment that will bypass a great many of those, and that's IVF. And that's why it's the most efficient, the most effective treatment in the setting of unexplained infertility. It doesn't mean you got to go right to that, right? A lot of people are very inclined to proceed with a stepwise approach to treatment. Let's start simply, do some IUI, see where that leads us, revisit IVF if and when we have to. Very supportive of that, but before we take off and do it, we need to think a lot about ovarian reserve, age, right? These are factors that don't get better with time. So it sounds like this individual's done 4 IUIs in the setting of unexplained infertility. Should they look for a diagnosis before IVF? Well, they got the diagnosis, right? Unexplained. I'd be very supportive of a transition to IVF at that point. Doesn't mean they have to, right?
Yep.
We're not cookbook readers here.
Yeah.
If they're happy with IUIs and it's going well and ovarian reserve is reasonable, no reason we can't do some more if that's what they want.
Yeah.
But we got to talk in depth and detail about the pros and cons of all available options, and IVF would be a much more efficient way to go at that point.
Yep. And here's the way that I typically talk to people about this, which is that when you think about an IUI, now you do have to account for age and each individual person. But if you're taking everyone and you're looking at unexplained infertility and a regular 1 IUI cycle, so you go through ovulation induction, you end up having your IUI, everything's optimized. So we know the person ovulated, we know that we did the IUI at the right time. that gives a couple about a 15% chance of pregnancy per cycle, which doesn't sound like very much, right? 15% doesn't sound like that much. But when you think of normal human reproduction for couples that don't have infertility, that rate's actually only 20%. And I always tell people, we humans are just bad at making babies with or without infertility. So it gets you closer from what I always tell patients, without any help, if you have unexplained infertility, which means that for a couple that's under 35, they've been trying for 12 months, their chances of pregnancy per cycle is around 3 to 4%. So it's not zero. They keep on trying for years and years and years, they'll probably get pregnant on their own. But you don't want to get pregnant 10 years from now. You want to get pregnant today, as soon as possible, and that's what we want to help with. So with an IUI, your chance is 15%, okay? So let's say we do one, it doesn't work. 2, 3. Each time, there's a roughly 15% chance. So what I always tell people is, by about 3 cycles, almost 50% of couples will have gotten pregnant that way. And so that's when I typically sit down with people. You've had 4. So at this point, I would have sat down with you and said, hey, let's just talk about it. Do we do more IUIs or do we move on to IVF? And one thing to think about with this is kind of what I mentioned before, the optimization of dollars for chance of pregnancy. An IUI is a lot cheaper than an IVF cycle, but it's not free, right? And so just like trying on your own, if you do enough IUIs, as long as the tubes are open and there's a relatively normal sperm number and motility, you'll probably get pregnant. Let's say it takes 15 IUIs. For one, that takes about 15 months or 15 cycles, right? And then each time you're adding that cost, right? So let's say you get pregnant after 15 IUI cycles. By then, you may as well have just done IVF. It probably would have been cheaper, and you would have been pregnant 15 months earlier. And so it's the idea of, once we get to that 3 or 4, we want to think about optimizing every dollar. And if putting in $1,500 for an IUI cycle is not going to give you that best chance, and we think it's going to take 10 more times, it's really, really worthwhile to think about trying other things. One caveat to that is everyone is, as you said, different, and their circumstances are different. I've had patients who their insurance will cover IUIs but don't cover IVF. Well, in that case, IUIs are the way to go. There's some people who, after just one IUI, they're like, I hate doing IUIs, I don't want to do it anymore. You can go right into IVF. There's no right or wrong. And I think we've said this previously. Everyone is unique. Everyone's an individual. There is no exact right thing for everyone. So we kind of do our best to give you the options and let you know what those numbers are. An IVF cycle with an embryo transfer, especially if we know that it's euploid, gives you a roughly 50 to 60% chance, at least, chance of pregnancy in most cases. So those are all things we consider when we're helping people to make those decisions.
All right. Well, here's another question. I'll let you tackle this. It says that we have had one successful transfer. Great job. Any tips or advice as we start preparing for another? The nerves are already there.
So this is a great question. I think that there's really 2 ways to look at this. I've sort of talked in my own TikTok page about sort of my own experience with this, and part of what you want to do is like, what can I do to prepare myself? This is, what can I do prepare myself mentally to get ready for this? There is so much anxiety that goes into every step of the infertility journey, right? So there's like the days leading up. Well, even if you go back to making embryos, there's the ovarian stimulation, there's the retrieval, how many eggs am I going to get? Then you got to wait and see how many embryos come. If you do genetic testing, then you got to wait another couple of weeks to see, how many euploid embryos do I have? And then now you've had success, and now you're pregnant, and you've had this baby, and now you've also, it sounds like, had another transfer that didn't work, and you're probably wondering to yourself, why did this first one work? Why did the second one not work? What was the difference there? And the reality is, for the most part, there is nothing that you need to stress about as far as, am I doing this one thing or this or that in my life that's going to make a specific embryo transfer more or less successful. I would basically recommend what I recommend to everyone for just general health, for anyone who's trying to have a baby at all. You want to be taking a prenatal vitamin. You want to be at a healthy weight. You want to make sure that any sort of chronic conditions that you have are either under control or have gone away. So if you have diabetes, you have high blood pressure, those are managed in a way with medications that we know are safe for pregnancy. So if I have a patient who is on something for their blood pressure, if they have diabetes and they're on certain medicines that I know aren't safe, I usually will have them see their OBGYN and then have them transferred to pregnancy safe medications in preparation. But other than that, you just need to be healthy, make sure that you're getting prenatal vitamin, stay a healthy weight, keep an active, healthy lifestyle, and just know that the most important thing comes down to the embryo itself, that you have a euploid embryo, and that when we do the transfer, we'll know the other component, which is the uterine lining. That's something that we will know before we do the transfer. So that part of it will be addressed. So it's really just stay healthy and do your best not to stress, which I know is very hard to do. I've been through that myself. But and one other thing that I talk about a lot is don't ever feel like you can get so stressed about your stress that it makes things not work. I think sometimes we tend to get into these like stress spirals where we're like, okay, I'm worried about stressing, and now that stress is making me worried even more, and then you sort of spiral. Don't do that. Just be healthy. Be excited about it. You know that you have an embryo that worked, which means there's a great chance that the next one can, and that's what I would say about that.
Yeah, absolutely. Here's one. We're doing reciprocal IVF. So those of you that don't know what that means, same-sex female couples, they have some unique options available to them, and one of which, some people call it co-IVF. That's where one member of the couple goes through the IVF stimulation part to get the eggs, and embryos are made, and then the other member of the couple carries the pregnancy, right? Pretty cool. So they're saying that they have done the first part of that. Meaning they have some embryos. That's awesome. What is the embryo transfer like? All right, so that's segment number 2 of the IVF process overall.
Mm-hmm.
I usually tell people that embryo transfer cycles are a lot easier than the stimulation. Not that the stimulation's bad, right?
Mm-hmm.
But with embryo transfer cycles, at least in our hands, it's a couple weeks of estrogen tablets to make the uterine lining, the endometrium, thicken and grow. And I always tell people you should feel normal during that time, and we leave you alone during that time, meaning you're not coming back and forth to see us for appointments every couple days. Mm-hmm. After a couple weeks, one ultrasound, make sure the endometrium looks good. And then, and that phase is flexible, right? People are not machines. They're not going to have a perfectly predictable response every single time. We got to look to be sure the uterus looks good. Some people need a little bit more estrogen. That's okay if we have to extend it a little bit. You can be on estrogen for 2 weeks. You can be on it for 2 years. It doesn't really matter.
Right. But
the minute we start the next medicine, the next phase of the transfer, which is progesterone, which transforms the endometrium, gets it ready for that pregnancy. There is a high degree of specificity involved in the timing between when that progesterone starts, when we do the transfer, roughly a week later. There's a little bit more to it than that. Various ways to give progesterone. We tend to use the progesterone injection, right? Nobody looks forward to it, but everybody does fine with it. Once we got that positive pregnancy test, we can talk about transitioning to some other routes of delivery if we have to. Mm-hmm. So basically, it's estrogen for a couple weeks. We do a special ultrasound before that to make sure there's no polyps in the uterus. Lining check, make sure it looks good, start progesterone, and about a week later, do that embryo transfer. That's a procedure not to be worried about in terms of pain or anything. Wide awake for that. Your partner will be there with you. And we all get to watch together on the ultrasound. It's a pretty cool process. So that's our standard way to do it. There's also ways to do embryo transfer preps that are based around a natural cycle. Sometimes we'll tweak a couple things with that natural cycle and call it a modified natural approach. Those work great too, and people have different reasons for wanting to consider the different ways of getting a transfer cycle ready, which we can certainly talk about, and we're open to making it individual for different individuals and couples.
Yeah, I think that's exactly right. I always tell people that embryo transfers are they're the most momentous part of the process, because all this work has gone into making these embryos, but they're also one of the most simple things that we do. It's the thinnest catheter that we have. We do it under ultrasound guidance. By the time that we get to the embryo transfer, almost all the variables have been addressed that could possibly come up. And so there's a lot of anxiety that goes into sort of that time when it's coming for patients. But once you get there, you'll be amazed at how smooth and easy it actually is.
Yeah, I always tell people that so long as it's easy, sometimes they're not, but so long as it's easy, they are uneventfully quick.
Oh, and another really important thing, and not everyone does it this way, but this is how we do it. When you get to the point of when we're doing the actual procedure, doing the embryo transfer, I always tell the patients on the day of, think of it in 2 phases. The first phase is the hard part. That is if it's going to be hard, which is putting the external catheter through the cervix. That's kind of like creating like a little safe tunnel for the internal catheter. The external catheter, the embryo is hanging on this little petri dish. It's safe, it's healthy, it's just waiting there. It's perfectly fine. So if there is anything's a little complicated, or if it's a little bit more difficult than normal, we'll address that while we're putting that external catheter in, and all the while, embryo's nice and healthy and safe.
It's tucked in the lab.
Yeah, it's just hanging out there. And then after that, then once we know for sure that we have a direct line, which we see under ultrasound, then the second phase begins, which is where the embryologist brings in the internal catheter that does have the embryo in there. But by then, we already have our perfect path going straight into the uterus, so we know it's going exactly in the right direction. There is another thing that we can do too, is that if, for instance, we get that external catheter in and we're like a little worried, like maybe this isn't going to go, the internal catheter isn't going to pass as easily as we think it's going to, you can do a trial of transfer where they just bring in an internal catheter that doesn't have an embryo, and then we have another way to be sure that everything's going to go smoothly. So there's a lot of ways along that path and during that procedure that we can be sure things are going to go correctly. So as I said, there's a lot of anxiety that can go into it, but we have everything addressed all along the way during the procedure itself.
Sure. Are there any ways to increase a thin lining? I assume you mean during the process of embryo transfer prep that we just talked about, the job of estrogen is to make the lining, the endometrium, thicken and grow. So then you come back for the ultrasound. We want it to look good. People always ask me kind of what do I want, and I say, well, I don't know, maybe 7 millimeters or more, something like that. But in some people, it's just not. And that's frustrating. It's frustrating for patients. It's frustrating for us because we just want everything to be perfect. Now, the endometrium is a complex tissue. It does really amazing things. In a natural cycle, it grows, it changes, it sheds, it regenerates. Yet our ability to assess its function is limited, right? And I would argue measuring from point A to point B is not a really super elegant way of assessing
Right.
a complex tissue, right? I believe strongly that how it looks, right? There's a certain appearance that you just know that endometrium is well proliferated, it looks good, and I don't really care what the thickness is, right?
Yeah.
But as we said, estrogen phase is flexible. We'll probably extend it by a week or so because the response to a drug is dependent on both dose and duration, right? So giving it a little bit more time, come back in a week, check. If we've gotten some more growth, okay, wonderful, we've achieved it. But what if we haven't? Well, if it still looks good, we know we've given it a chance, it's maxed out. As long as there's not a complicated uterine history of infections and surgeries, things like that, that endometrium is going to be fine almost every single time.
Mm-hmm.
I mean, I've been through this process of thought and angst and worry a million times, and I bet in almost every single one of them, that embryo implants just fine.
Yeah.
So I don't think there's really a place for exotic interventions. There are several, right? Sometimes people talk about using medicines used to boost white blood cell counts in chemotherapy settings called Neupogen. The data is not strong for that. One that a lot of people seem to know about is aspirin. Well, that's not a terrible thing to have on board. And usually we do with our transfer cycles anyway, probably a blood flow thing. Kind of an interesting one is Viagra, right? Tell your friends, hey, I'm taking some Viagra for my uterus, right? I personally have never prescribed that.
Yeah.
I tend to just have enough faith in that endometrium, even if it's not as thick as we'd like, that it's going to do just fine.
And this comes back to sort of what I was saying before. There's some things that we know work. We know the things that we just talked about, having a good-looking endometrium that looks, we would call it trilaminar. Yeah. That's sort of the term that we use in the sort of medical world, that it looks right. We know that means that it is a kind of endometrium that is going to respond to progesterone, and as you said, it almost always works just the way we expect it to.
We don't need to break records, but we will give it a chance to get a little bit thicker if it's not exactly where you might not think it needs to be. All right, Dr. Theisen, how about this one? What are the odds of fertility after a ruptured ectopic pregnancy and removal of one fallopian tube?
Okay, that's a great question. And I always like to say that we have two of every important thing, and the tubes are no exception to that. So there's some really important things to think about, though, if you've had a ruptured ectopic pregnancy. So I think the very most important thing is that when you've had an ectopic pregnancy in one tube, there is a possibility that the other tube is also damaged. And so we want to make sure that other tube is functional before sort of moving forward with sort of fertility treatments, or maybe even trying to attempt to conceive naturally on your own, because what we don't want to do is end up with another ectopic pregnancy, obviously. So my recommendation, just before we get to the question, is I would contact your OBGYN or us, an REI doctor, to do an HSG to evaluate that tube. But we want to make sure not only is that tube open, but two, does it look like there's any signs of disease? There are some signs outside of the tube just being open that could point to some inflammation in the tubes. depending on your reason for having tubal disease, and there are a couple of different reasons that I think about. One are for when pelvic surgeries. So if you've had any kind of ovarian cyst, that might point more to just one. So let's say that the tube that you had removed, you had a surgery on that side of the pelvis. Well, it's much less likely that the other tube is going to be damaged by that. On the other hand, if you had a sexually transmitted infection that damaged the tubes, well, there's not a small chance that it affected both the tubes. And so you want to be sure that other tube is healthy and safe before you try to conceive without looking. The other thing would be like endometriosis. We know endometriosis can also affect tubes from the outside. So all of those things, I would say the most important thing was check the other tube first. Now, to get to your question, your chances of fertility are great. Once we see that tube is open, this is why we have two of everything that's important. That tube will work just as well as if you had two of if the other one was functional as well. One of the things we were talking about before we started doing this video is, well, if you have an open tube, and let's say we're doing an ovulation induction cycle, and we see that the egg is growing or the follicle is growing on the opposite ovary. So you have one tube that's open and no tube on the other side, but the ovary on the opposite side is the one that has the follicle that's growing. What should you do? Well, so there's definitely data to suggest that you can get pregnant using an egg, an ovary on one side with the egg and the tube on the other. That definitely happens. But you have to think about cost, right? Is it worth the money that goes into paying for the sperm to be processed for an IUI, if that's what you're doing? Is it worth the cost of the procedure of doing the IUI? Because we know the chance is going to be a little less, even though it's possible. So in that situation, we may cancel that cycle and do another IUI. Sometimes in the past, what I've done is I'll increase the dose of medication to maybe get more than one follicle so that we can hopefully get one on both ovary. So that is, I would say, very clear. You can definitely still get pregnant. If the only issue that you have going on is tubal factor and the other tube looks healthy, I think your chances are great. And even if that other tube is damaged and there looks like there's an issue there, IVF bypasses that, and you can not worry about the tubes because we just make the embryos in their own little dish in vitro, and then we put them in the uterus, and you don't need that tube at all. So one way or another, if all the other factors are sort of normal except for that tube, the answer to your question is you definitely have a great chance of fertility with the remaining tube that you have.
Sure. Okay, here's our final Instagram question. We've got a few from Facebook as well, it appears, but what do you recommend for recurrent pregnancy loss and endometriosis? Do you do surgery or just go to IVF? And I think we could probably talk about that for a couple hours. And the answer is really it depends on what the goals are. I think, endometriosis is a funny condition. There are people who have had all the kids they want, no infertility, no pain, and then let's say they go get their tubes tied one day and you're like, dang, there's a bunch of endometriosis in there, right? But it never had any clinical implications. There are those who are utterly disabled by pain, and you go to surgery, to laparoscopy. That's the most effective treatment for or the most effective option for long-term pain reduction.
And really the only way to diagnose it effectively, too.
Exactly, is looking in there with surgery. But maybe that person who's just disabled with pain just has a couple specks of endometriosis, not much, but you treat it and they do great, right? So the way I practice is if the goal is fertility and there are no other factors at play, the answer is fertility treatment. And it doesn't have to be just IVF.
Right.
We would look at other factors like ovarian reserve and age and prior treatment, duration of infertility, because simpler treatments like IUI can absolutely be reasonable options as well.
Yeah.
Whereas if the primary goal is pain reduction, well, that's where surgery is going to be something that we recommend sooner rather than later. Sometimes it's both, right? Maybe if somebody is younger and has very reassuring ovarian reserve, that one factor that changes with time, if that's reassuring and makes us all warm and fuzzy, well, there's probably and likely plenty of time to maybe let's address this surgically, get the benefit for long-term pain control, and then focus on fertility. There's a couple well-known trials where they actually randomized people that they found endometriosis in surgically and treated it in some and just didn't in the others, and followed them, and it did not have a major impact on fertility whatsoever. And that's why diagnostic laparoscopies looking for endometriosis kind of went away before you and I both started practicing. So that's like I said, it's a complex subject. Everybody's different, but one that we're certainly prepared and happy to talk to you about.
Yeah. And then the other component of that too, the recurrent pregnancy loss, that part of it is going to basically, it's going to have to do with why you had recurrent pregnancy loss. There are some kinds of recurrent pregnancy loss that are rare, that really the only way that you can address it is with IVF. So I'm thinking of chromosomal abnormalities, genetic abnormalities in one or both of the parents, where when the embryos are coming together to make their 46 chromosomes they need, something about one of the two parents is sort of basically crossed, so that when you either making your sperm or making your eggs and you divide everything up, a large proportion of those eggs or sperm do not have the right genetic information to make a 46 chromosome embryo when mixed with the other sperm or egg. The only way to control for that is IVF and doing genetic testing. And really, that's basically a numbers game. You're just trying to make as many embryos as you can with the hopes that you find the egg or sperm that have the right amount of chromosomes to make what we call a euploid or genetically normal embryo. So and I've had patients like that recently, and where the only real solution to quickly helping them to get pregnant is to do it that way. In other situations, there are other reasons for recurrent pregnancy loss, things like antiphospholipid antibody syndrome. There are some uterine factors, things like uterine septums, but none of that necessarily means you need to jump right into IVF. There's really only a couple of things that we would say, IVF is the only way. A caveat to that is sort of similar to unexplained infertility, unexplained recurrent pregnancy loss. We don't know. That's the thing with unexplained recurrent pregnancy loss, which is also extremely frustrating for patients. Everything looks normal, so there's no uterine septums, the person doesn't have any blood clotting disorders, everything else looks just fine. In that situation, it kind of comes down again to the genetics of the embryos, and where you can say the only way to control for every single variable that could lead to early miscarriage, which many miscarriages, the majority, are because of genetic problems, the only way to control for that is IVF. So I would say an unexplained recurrent pregnancy loss, IVF as a first line is a reasonable thing to discuss, but not entirely necessary, as opposed to when one of the parents has a genetic problem, and then IVF might really be close to the only way.
Yeah, this particular question brought up recurrent miscarriage and endometriosis, but I wouldn't say that, I'm not ready to claim that endometriosis causes recurrent pregnancy loss, right? I mean, when it comes to recurrent loss, there's an evidence-based approach to that evaluation that we stick to here. There are places that might do some kind of funny things, and you got to be careful about that, right?
Yeah.
And something that we have to emphasize, and we do, that when the recurrent loss evaluation is negative, meaning there's no identifiable factor, there's no opportunity for directed treatment, the prognosis, the likelihood of having a live birth without treatments are really good, right? So IVF is there, yes, because we can test embryos and try to control for the most important cause of miscarriage, which is a chromosomally abnormal embryo that transiently implanted, right?
Right.
That's there, but that's not the first option or the first thought, right? And that really boils down to how an individual or couple values efficiency. What kind of trials and tribulations and disappointment have they been through so far?
Yeah.
What is their tolerance for more? What is their likelihood of success with IVF in terms of response? So it is a multifactorial decision-making process that we're here to go through with you.
Yeah, we say for everything that it's a unique, every person is unique, and I would say this is one of the ones where it's extremely unique, and every person is just different in how emotionally they feel about sort of the process. Some people are like, if we know that eventually we're going to have a live birth and we don't need to go through this whole process of doing IVF, we can do that, and the numbers are very, very good. Actually, whenever I have patients who have recurrent pregnancy loss, I bring up a graph that the studies that have looked at couples that have unexplained recurrent pregnancy loss, and the numbers are really surprising to them. Actually, that we're talking 70% or 80% who have had 2 losses will go on to have a live birth,
or even more.
Yeah,
even up to 6 losses. The odds of getting a normal progressing pregnancy are way better than most people think.
Yeah.
So.
Yep.
All right. Femara, also known as letrozole. Chances of ovulating it on it versus Clomid, another common fertility drug, right? This person looks like has PCOS. They've okay, great, been successful with Clomid.
Yeah.
Lost some weight, tried Clomid again, no success. What about Femara? These are similar drugs, right? Clomid's been around a long time. It's one of the oldest fertility drugs, simple drug, inexpensive. You take it on out, typically about 5 days, and it tells the brain to release the amount of hormone it releases called FSH, follicle stimulating hormone. It tells a follicle to grow, right? So PCOS, The most clear and consistent clinical manifestation of that is not ovulating as you should. Hard to get pregnant, if you're not ovulating, right? You said before, humans are inefficient reproducers. If you factor in unpredictable ovulation or not ovulating, it makes it extra inefficient. So Clomid, letrozole, they're both examples of ovulation induction agents. If the brain can send out a stronger signal, it can get that ball rolling. And Clomid's been used for decades. And it worked for you, and that's great, and it's worked for plenty others as well. Now, a very common question is letrozole, also known as Femara, that's a brand name, is it better? That was looked at in a real important trial called the PCOS 2 trial, where they compared head-to-head Clomid, letrozole. And they found significantly, but I'd argue not impressively, better rates of achievement of ovulation and live birth with letrozole over Clomid in this population. So that's usually my go-to in the PCOS setting.
Yep.
The opposite's true for unexplained infertility, at least in my hands, but that's a story for another day. Why would one be better than the other? They work a little bit differently, but their end net mechanism of action is the same. Well, there is a subset of women who, when treated with Clomid, their endometrium doesn't grow as well. Not everybody, but that's something we look for, and that's another reason to monitor these cycles. Some doctors out there might not monitor their response in terms of not just the ovary and follicle growth, but also endometrium. So if you're monitoring it, you can catch it and be like, whoa, that endometrium's just not growing like we want it to.
Yep. And
it very well, and they tend to do much better with letrozole. So it's always been my belief that could account for some of that difference.
Yeah, that's what I've always thought too.
But if the endometrium grows well, ovulatory or ovarian response is good, and especially if you've been pregnant before on Clomid, I can't say that Clomid is necessarily an inferior drug in your case. And there's also some side effects and things like that we talk about. So they're similar drugs.
Yeah.
But in general, yes, letrozole, Femara is step one when it comes to ovulation induction in the PCOS setting.
And just to add to that, one thing about sort of what I call with patients or isolated and ovulatory infertility, where essentially you do the full workup, everything looks normal, except as the patient says, I only ovulate or I only have a period every 3 months, or I only have a period every 6 months. So they have a diagnosis, maybe not even fully PCOS, but a diagnosis of anovulatory infertility, where we know ovulation is the issue. In those patients, those are the only subset of patients that I really recommend our most basic treatment. So for you, this is just something to keep in mind, that for those folks who ovulation is really the only problem, where it's just getting the egg out of the ovary, those folks have a really good chance of getting pregnant with just ovulation induction, so help you to ovulate with whatever type of medicine that you use and whatever dose it takes, and then you just have intercourse at the right time. Those couples will have close to a 20% chance. That's more, again, than unexplained infertility, right? So if we just help you to ovulate, you have intercourse at home, your chances rise to almost the level of just a couple without infertility with our most basic form of treatment.
It gets them back in the game, back to a level playing field.
Exactly. And what I always tell people is, if we can just get the eggs out of the ovaries, then the rest of the mechanics should really work as intended, and often they do. And so for someone like you that has PCOS, and we'll sort of assume that everything else looks normal, I always tell patients that's actually not a bad thing at all, because it means we can help you most likely with some really, really basic treatments.
Yeah, and there's a good side to PCOS. The egg number, the ovarian reserve, the quantitative ovarian reserve tends to be well above average, right? And I always tell people I'd much rather deal with not ovulating, because we can do that pretty simply and easily, than the other end of the ovarian reserve spectrum, where there's severely diminished ovarian reserve, because
that's much harder.
It's a much more challenging thing to face. All right, I'll let you read this one, then the last one's kind of fun. We can talk about that together.
Okay, so this person asks, I'm currently taking vaginal estradiol 200 milligrams. Am I guaranteed to have a cycle by the end of week 2? So this one is a little bit, I might need a little more information on this one. So I'm kind of unfamiliar with estradiol 200 milligrams vaginal. That seems like a lot of estrogen. We typically think of estrogen being delivered in maybe 2, 6, 8 milligrams at a time. So 200 would be a lot. So I think you might be...
I bet they mean progesterone.
I think you mean progesterone. Yeah, that's my guess. I think we're talking progesterone. And so the way to think about sort of the relationship between having a period and progesterone. So as Dr. Tarnawa said, the first part of anyone's cycle, so right when you start having your period and then moving forward into the point where you eventually ovulate, that part of the cycle is all driven by estrogen, right? So it's estrogen. And if we give you estrogen, your uterine lining will just stay there. And people with PCOS, they have really high estrogen levels sometimes, and their lining just stays really thick, right? So if you have estrogen in your body, that's going to make the lining thick. Progesterone has sort of the purpose of supporting and sort of, I describe it, if estrogen is the bricks of the lining, then progesterone is kind of like the mortar. It stabilizes the uterine lining. And your body has a very, very sort of impressive way of stabilizing the lining. Progesterone drops down, and then the uterus basically knows, okay, there's no pregnancy this cycle, and that's when a period happens. That's how the lining sort of knows it's time to come out for a period. So when we give someone progesterone, it kind of fools the body into thinking you've just ovulated and that progesterone level's high. So you sort of stimulate those receptors in the endometrium, in the uterine lining for a certain amount of time, and then you stop the progesterone, so the level comes down. And if you think about it, that progesterone is also suppressing the hormones that are coming from your brain, so your ovaries won't be doing very much either because of that suppression. So basically, progesterone's high in your body, and then it goes down. So the uterine lining thinks, oh, it might as well be a regular cycle, progesterone's low, and you have a period. So if you're on progesterone, and the reason you're not having periods has something to do with elevated estrogen, like anovulatory cycles or PCOS. If your progesterone level gets high enough, and then it comes down, you should have a period. But there are other reasons for not having periods, and so if you don't have a period after progesterone, that should sort of clue in your doctor to start looking for other reasons why you're not having a period. But it's very much, progesterone. I'm not sure about vaginal progesterone, but certainly progesterone is one of the key diagnostic tools that we use to differentiate the different reasons why people aren't having periods. So if that's what you mean, I think that I would not be surprised if you have a period, but if not, there's going to be some additional diagnostic steps to go through to see what's going on.
Yeah, the progestin challenge test,
Yeah.
right? I mean, things you have to be sure about is adequate estrogenization of the endometrium prior to progesterone, and adequate exposure to it. So, I mean, 3 days of progesterone then stopping, probably not going to lead to a period. It needs to be at least about 10 days. So 2 weeks should be sufficient. But
Yep.
if there is what we call a negative progestin challenge test, you take a sufficient amount for sufficient time and no period, that calls for more advanced workup,
Yeah.
and we can do that ourselves or in conjunction with your gynecologist.
Yep.
All right, like I said, we have a fun question to end on. How can I get my embryos to Summerville, South Carolina from Las Vegas?
I guess everything that happens in Vegas
How
doesn't
can you-
necessarily stay in Vegas, right?
How can you get me to Las Vegas from Summerville?
Yeah, seriously.
Right?
So it's actually a very straightforward process. So this happens all the time, actually. Transfer of embryos, transfer of sperm, transport of eggs. There is a process by which labs communicate with each other and facilitate this transport of various reproductive products, embryos, eggs, sperm. We see this in frozen egg donors, where we get egg donor agencies send eggs. There is embryo donation, people that will adopt embryos. And those embryos get sent. People just like you that may be moving. My own embryos started off in Augusta, Georgia, and then traveled all the way to Chicago, where they finally had their transfers. So essentially what you do is you would talk to wherever so for us, you would talk to Craig. You just let us know that you want to do that. Our lab would talk to your lab, and that's almost it. You have to sign some paperwork to say that you want this done, and then we take care of the rest. They are shipped at a negative 80 degrees, just like they're kept frozen at, and then they make their way here, go straight into our freezers, and it's as if they never even traveled at all. I always say the embryos are basically frozen in time. It's so cold that that nothing will happen in that transport. When you work with like a long-term storage place, like a Reprotec, there are some things that there will be in the paperwork about things you can do to kind of ensure your embryos. So when we have people sign Reprotec paperwork, I always thought it was kind of funny because you could have like your embryos shipped in 2 different shipments. I don't know if you've seen this. So basically, you can have it's like you can put if you have 8 embryos, you can take 4 of them, and those go in the first truck, and the next 4 go in the next. And I always would describe to patients as if if the first truck goes off the side of the road, the next one keeps going. I always thought that was kind of unnecessary, but there's also some insurance you can sometimes purchase for embryos that are being transferred. But in general, and I have never seen it outside of this, so I could say pretty much exclusively in my experience, that process is pretty seamless and the embryos make it no problem.
Yeah, I mean, it's something that always worries people a lot, and rightly so. But in terms of your case, we'd love to get to know you. Really, step one would be to schedule an appointment with us. We can learn about your history. But prior to embryo acceptance, and this is where it gets serious, you know, we would need to carefully review the clinical circumstances around when those embryos were created. We would have to make sure that all the documentation at the existing center is perfect, right? We got to make sure identities are for all parties are confirmed and triple checked and verified before we can accept embryos. We got to make sure that documentation's right. But once we've done that and made sure that's the right thing for you to continue treatment with these embryos, then our embryology lab team would coordinate theirs. And as Dr. Theisen said, Dr. T, it's a very smooth process.
Yeah, it is. All right, guys. Well, I think that is all the questions. As always, we very, very, very much appreciate these questions. And these questions are getting better and better, and we really love talking to you about this stuff. There's some really, really good things, and we hope a lot of people I know that there are people who have the same questions that you guys have had. So keep them coming. We will answer them as they come, and thank you again.
Yeah, thank you so much, guys. We hope it's helpful. This is a relatively informal setting, and there's a whole lot more to discuss and talk about for all these. We can't give individual direct medical advice in this forum. That's why we want you to give us a call, schedule an appointment. We will talk all about it. But again, coming to you from Prague, from our Low Country Center, Somerville. We're also in Mount Pleasant. We have centers throughout the state in both North and South Carolina. This has been Tea Time with Dr. T and Dr. T.
All right, thanks, guys. Until next time. Bye.